Welcome for a new presentation in Easy and Different Radiology. I am Dr. Osama Ibrahim. Today our appointment number 2 in cranial nerves. As I promised you in the previous presentation, today and in the next presentations I will talk about the pathology of the cranial nerves. In the first presentation in the previous week I talked in anatomy, and in the today presentation and next presentations I will talk about the pathology of the cranial nerves. So let's start. The learning objective from my presentation today is optic nerve pathway. I will talk about the pathway of the optic nerve. Then I will confirm the sensory origin of the optic nerve, and also I will talk about the different pathology and how to differentiate the different lesions in the optic nerve when I present. The target audience from my presentations in this current presentation, this presentation is useful for the practical clinical radiologist who is working already in the clinics because some of these lesions I will talk about today will be phased during the work. FRCR2A and 2B candidates who prepared for the exam also will be benefited from this presentation today because I will talk about some lesions which may be asked in the oral Viva exam or in 2A written exam. Also in EDiR candidates and other boards like Arab boards or other boards can be candidates who prepared for these exams can be benefited from the current presentation today, as well as the neurologist who's already. So let us talk about the optic nerve pathway. As we see, there are two orbits, so both orbits can receive the signals, light signals from the objects, and then the signals is transferred and pathing in pathway until reaching to the final terminations as the occipital lobe as a visual center. This pathway is involving the ocular itself, which is the posterior segment of the ocula. It is the retina. In the retina, the signals can be received and converted through the photoreceptors to the neural cells after that. The optic nerve after that is the second stations which taking the signals. The nasal fibers of the orbit transferring the signals and crossing it to the opposite occipital lobe. The nasal fibers from this orbit also going to the left occipital lobe, for example, right ocular to the left occipital lobe, only the nasal fibers. However, the temporal fibers sending the signals in the same occipital lobe, so this can be cause some pathology which can be asked in the questions which written in the 2A exam is concentrating in this issue. So the first synapse here is at the optic chiasm, which is located superior and anterior to the pituitary gland. So this is the optic chiasm. After the optic chiasm, the fibers is going through the two lateral geniculate bodies through the optic tract. So this part is called optic tracts, transferring the signals to the geniculate body. The geniculate body, I will talk it in the next slide. After the geniculate body, the optic radiations sending the signals to the cortex, occipital cortex, and the visual center. So one from the stations is very important stations is the lateral geniculate body. This lateral geniculate body is anatomy is located lateral to the medial geniculate body, and also it is lateral to or in relation to the superior colliculus of the midbrain as a trigeminal segment of midbrain. The anterior to it and the lateral is the optic tract coming from the optic chiasm, as we talked in the previous slide. After that, the synapse here in the lateral geniculate body, then the fibers going through the optic radiations, which transfer the signal to the cortex, as I told before, in the occipital loop. So this is the pathway of the optic nerve, which sending the signals to the occipital loop, and all of this optic nerve is sensory. And I talked in these slides in the previous presentations when talking for the anatomy, the signals to summarize transferred from the retina here through the optic nerve, and then passing from this foramen, optic canal foramen, and then decussates through the optic chiasm, and then it passing directly to the optic radiations, optic tracts to the lateral geniculate body, then optic radiation to the occipital loop. And now the main part from my current presentations is the differential diagnosis of the pathology of the optic nerve. Optic nerve, as you know, this is the cranial nerve 2, because the cranial nerve 1 is the olfactory nerve and 2 is the optic nerve. Both of them are sensory, and the differential diagnosis of pathology which can be happen in the optic nerve, and this part from presentation is very important for the candidates who enter to the exams, as I mentioned, FRCR, EDiR, or board, because sometimes the questions here sometimes become difficult, but if you don't know the differential diagnosis, you can differentiate it easily, as you will see through my presentation today. First one and the most important one is optic pathway glioma, and optic pathway meaning optic nerve itself glioma, and any part from the optic pathway which I talked in the previous slides can occur the glioma on it. The most important and the most important one which can come in the exam and become a difficult question is the optic chiasm glioma as a part from the optic pathway. I will show you one case of optic chiasm glioma in my presentation today. The second most important pathology in the optic nerve is the optic nerve sheath meningioma. So optic nerve sheath meningioma is one from the most famous pathology in the optic nerve, and you should differentiate between both glioma and meningioma, because this is very famous question during the any exams, master, board, FRC or EDiR. You should differentiate glioma from meningioma. I will give you a schedule at end of my presentation today to make it easy differentiations between both. The third pathology which can occur in the optic nerve is the neuritis, and neuritis one from most important also pathology can occur in the optic nerve. The neuritis, I will talk about the neuritis in my presentation today about three types, differentiate three types of neuritis: acute optic neuritis associated with multiple sclerosis, ischemic optic neuritis, and Devic disease, as we will see in the next slides. Let us talk first about the optic nerve glioma. The optic nerve glioma is the most common cause of the optic nerve enlargement, and it is found in children less than 10 years of age, 80% and 20%, 80% of them less than 20 years age. Neurofibromatosis type 1 is one from the associated by the optic nerve glioma, and if you faced by optic nerve glioma, you should exclude possibility of neurofibromatosis through searching and screening of the patient for other abnormality which could be related to NF1. I will make another presentation which differentiated by NF1 and NF2 later after I finishing the set of the cranial nerve. MRI finding of optic nerve glioma, it appeared high signal in T2, patchy enhancement, and this is very important. Second one is very important, the kinking or buckling, sausage shape, or fusiform dilatation or enlargement of the optic nerve. This is very important sign to differentiate optic nerve glioma from other differential diagnosis. If the optic nerve glioma extending through the optic nerve through the canal, so the optic canal it shows also widening, because this glioma is a benign lesion which could be causing bone remodeling. Like this case of optic nerve glioma, it is called bitter optic pathway glioma because the optic nerve itself or its pathway through chiasm, through tract, through radiation, optic radiation, any part can occur the glioma on it. The optic nerve pathway glioma so is very proper description for that glioma. If you see the optic nerve like this, is fusiform or kinking, enlargement as well as dilatations and widening of the optic canal, so at that time it described as optic nerve glioma. This patient is associated with NF1, so we should exclude other causes of NF1. Bone of the optic canal shows remodeling due to these benign lesions growing over time, so it causes bone remodeling. This is another examples of difficult questions or difficult case which can come in the exam, particularly in FRCR Part 2 exam in the recent or in the new form, which is showing short cases. You can bring case like this, which shows enlargement of optic nerve. In the sagittal image here in T1, only the optic chiasm is showing enlargement. This is a pituitary gland, and this is the infundibulum, and this part is the optic chiasm. Optic chiasm appeared thickened and enlarged. This case of optic chiasm glioma through the pathway. And this is post-contrast study showing patchy, less or poor contrast enhancement for the glioma, but the enlargement of the optic chiasm is diagnostic for the optic nerve or optic chiasm glioma. So this is one example which is difficult to detect in exam if you don't consider it in your mind. So optic chiasm or optic pathway can occur the glioma through it. One from this pathway is very important is the optic chiasm, which is showing here as optic chiasm glioma enhancement in post contrast and diffuse enlargement in the T1 weighted image. The second most important pathology is the optic nerve meningioma. Optic nerve meningioma also benign and slow growing, arise from the arachnoid layers which are surrounding the sheath of the optic nerve. MRI finding, this is very important, trim track appearance of enhancement because the tumors in the optic sheath, so it causing the optic nerve itself appear normal within the surrounding enhancing tissue of the meningioma. Calcification, one from the most important features of meningioma, if it is occurred in the patient, it is highly diagnostic for that. But it is only occurs in 50% of cases. Hyperostosis also one feature for meningioma for the surrounding bone. Meningioma in any place in the brain can cause overlying bone hyperostosis. So this is if it is present also, it is a features which prove the diagnosis of optic nerve sheath meningioma. And this is an example of optic nerve sheath meningioma in the CT. If you look at the CT here, this is the optic nerve which appeared normal and surrounding by enhancing mass as the optic sheath. Also in sagittal view, you can see the enhancing mass in the surrounding to the normal caliber of the optic nerve, and this is one feature which is called the tram track appearance or tram track enhancement, one features which is diagnostic for the optic nerve sheath meningioma. The third pathology which occurs in the optic nerve, which I mentioned only the most common pathology in the optic nerve. So neuritis, one from these, optic neuritis occurs in 60% of patients with optic neuritis go on have diagnosis of MS. So if you find neuritis, you should exclude possibility of MS in this patient. However, the neuritis can occur in other causes, as I will mention in my presentation today. MRI is very important for diagnosis. It could be unilateral or bilateral. In children, become bilateral. Enlarged and enhancing optic nerve, or typically hyperintensity in T2, and search for other features of MS in the brain or in white matter of the brain. If you look for this diagram meaning that if there are retinal atrophy it can cause visual cortex atrophy in the occipital lobe. And retrogradally also, if there are cortical center, visual center atrophy in the occipital lobe, with the time it transfers through the optic tract or optic pathway, the abnormality to the retina and causing retinal atrophy. So it is antegrade or retrograde pathway for the atrophy of both alternatively retina and the visual cortex of the occipital. In cases of neuritis, ischemic optic neuritis, it could be appeared like this in the STAIR image, and the STAIR image meaning short TI inversion recovery sequence, and this short TI inversion recovery resulting in suppression of fat, and if there are any pathology here appeared bright. So as we see here, there are bright signals bilaterally through the course of the optic nerve. However, the optic nerve itself, caliber, is not enlarged. Surrounding, there are no masses, so optic glioma and optic meningioma respectively are excluded. So if you find abnormal signal in the normal caliber optic nerve, you can describe it as a neuritis. Optic neuritis could be neuritis due to ischemic optic neuritis, could be part from MS, and could be part from DIVIC disease, or as I will describe in the next slide. So in the STAIR, you can find it as abnormal high signal, and in post-contrast study, you can show the enhancing nodules in the optic nerve which appear normal caliber. So at the times you can describe it as optic neuritis. This case of ischemic optic neuritis because there are no demyelinating foci or plaques in the brain, so it is not described as part from MS, and there are no transverse myelitis, so it is not described as a defect disease, so it is due to ischemic optic neuropathy. And ischemic optic neuropathy in post-contrast shows also enhancement because the neuropathy or neuritis of the optic nerve can be seen here showing focal contrast enhancement compared with normal optic nerve in the other side. So these features should be take it in your brain also when you thinking for the optic nerve pathology. This is another case of neuritis. However, this neuritis, there are abnormal signal, enhancing signal through the posterior component of the left optic nerve through the optic canal. However, it is associated also with plaques which perpendicular to the lateral ventricles as we see here, causing manifestations of demyelinating disease. So with multiple sclerosis could be causing, it could be part from the neuritis and multiple sclerosis. It's called like this, acute optic neuritis in multiple sclerosis. This is STAIR image or this is FLAIR image, sorry, this is FLAIR image showing abnormal high signal foci perpendicular to the ventricles, confirming the diagnosis of multiple sclerosis with this enhancing component in the optic nerve. So this is descriptions of the disease, acute optic neuritis in multiple sclerosis. Optic neuritis, in these diagrams, no need to read all these. This only compare the normal side from the abnormal side. The optic neuritis causing uveitis, causing retinitis, and the fibers also of the optic nerve itself, it shows abnormal deposits of these degenerative cells. So this scheme to showing the optic neuritis compared with the normal optic pathway. The DIVIC disease, one from the could be considered one from special form of multiple sclerosis. However, it is characterized by optic nerve abnormality and spinal cord abnormality. So it could be detected during doing cervical MRI, and you can see abnormal signal in the cord. So at that times you should exclude also abnormal signal in the optic nerve to excluding this disease or this DIVIC disease. DIVIC disease is neuromyelitis optica. This is the other name of it. Neuromyelitis optica is autoimmune with demyelinating disease. So the third or the triad should be spinal cord involvement, optic nerve involvement, and the third part from triad to diagnose the DIVIC neuromyelitis optica is autoimmune antibodies, which neuromyelitis optica antibodies which can be detected in the lab. Radiologically, also extended myelitis, as I mentioned in the cord. This is one diagnostic feature for the DIVIC disease. So when you faced optic nerve lesions, you should exclude also this DIVIC disease through examination of the cord if there are any abnormal signal in the cord. And now let's test our knowledge with little cases to differentiate the pathology of the optic nerve. This MRI with contrast, axial and coronal imaging, the abnormality in the right optic nerve. What is this abnormality according to my presentations and differential diagnosis? Glioma, meningioma, or neuritis? This is enhancing optic nerve itself and expanding of the optic nerve, so this is diagnosed as optic nerve glioma. Next case. T1 axial image with contrast showing enhancing lesions surrounding the optic nerve which appearing thinning inside in the center of the lesion. So if the enhancing like this in surrounding the optic nerve and the optic nerve caliber is not enlarged or kinked or fusiform enlargement, so at the times we can diagnose the tram track enhancement, which is diagnostic for the optic nerve sheath meningioma. This is another case. There are abnormality in the optic nerve in the right side and there are abnormality in the cord. Focal high signal in the cord in the stir image, and also there are focal enhancing component in the right optic nerve. So at that times, if there are both together and the optic nerve itself normal caliber, so at that times we diagnose it as a neuritis. Which type of neuritis? Ischemic or associated with multiple sclerosis or DIVIC disease. If there are transverse myelitis like this, so DIVIC disease is highly suggestive in this case. How can confirm DIVIC disease? If you find these two, you should make triads and you should make lab test for the antibodies of the neuromyelitis optica. This is the last case. Look for the optic nerve. This is compare the size of optic nerve in both sides. The optic nerve here is kinked and fusiform dilatation, so the optic nerve itself pathology, and this is the T2 image because the high signal in ocular fluids, and also this is fluid surrounding the optic nerve, so there are no enhancing tissue, only the abnormality in the optic nerve, so the optic nerve pathway glioma. And now I want to finish today's lessons with a couple of notes and to summarize my presentation. If you find optic nerve pathology, the optic nerve is not normal, so you should think one from three: glioma or meningioma in optic sheath, or neuritis, and neuritis should be differentiates ischemic neuritis or neuritis associated with MS or neuritis with DIVIC disease. And this is the last slides, differentiations between glioma and meningioma. Glioma always occurs 80% in less than 20 years. However, meningioma in the middle-aged, particularly women. Glioma is variable enhancement, patchy enhancement. However, the meningioma is tram track enhancement. Calcifications is more common with meningioma, and buckling of the nerve itself causing this is occurs with glioma. However, the nerve is straight and tubular in the optic nerve meningioma. At the end, the glioma in the optic nerve often asymptomatic. Sometimes it is part from NF1. However, meningioma is there are visual impairment appearing early, and also meningioma is part from the NF2. And at the end, these mnemonic words to remember the sensory and the motor cranial nerves. The cranial nerves are 12 in number, and you can remember the sensory, motor, or both from this mnemonic word. Some say Mary money, but my brother says big brain matter most. And you can arrange the cranial nerves from 1 to 2, olfactory, optic, oculomotor, and so on until the hypoglossal 12. And these mnemonic words can remember you sensory from motor and both, as I mentioned in the previous presentation. At the end, I hope I provide you with clear knowledge about the cranial nerve to optic cranial nerve. With me every Friday for a new cranial nerve pathology. I will try to make this set for all cranial nerves as possible to mention the most common questions which come in the exam. And also, I would like to remember you that I will make a new channels. I will talk it in Arabic in these channels, and my presentations will be every Monday. It will be starting from next Monday. At the end, thank you very much. At the end, I hope I provide you with clear knowledge about the optic nerve. If you like the video, you can watch more than 160 videos, all of them talking about radiology, and you can search it easily by searching Easy and Different Radiology in Google and Facebook. Thank you very much and good luck.